بسم الله والصلاة والسلام على رسول الله وعلى آله وصحبه ومن والاه. Okay, so our talk is about patent Foramen Ovale, PFO, and cryptogenic stroke. And we'll try to come over and review the literature and what they say about, comparing the device closure versus medical treatment. Just before that, a quick review about how the atrial septal develops, in the from before birth. As you know that the PFO is a result of incomplete attachment of the primary septum and the secondary septum, leading to persistent opening. Two types of PFO one is without the aneurysm, as we can see the simple PFO, relatively lower risk, versus the PFO that is associated with an aneurysm. This is a feature of what we call high risk type of PFO. So my first case I'd like to share with you is a 29-year-old female with no significant past medical history, presented with left hemiparesis back in 2012. She had history of oral contraceptive pills used for the last 5 months prior to presentation. She had negative workup for antiphospholipid antibodies screening test. Her ECG Holter, of course, we didn't have implantable recorder. There was no significant arrhythmias. She had ultrasound of her lower extremities. She had extensive left lower extremity DVT with heterogeneous thrombus from left common iliac femoral common iliac vein down to popliteal vein. CT and MRI were consistent with a stroke in the right basal ganglion with hemorrhagic conversion as well. And as you can see here, her DVT with compression, there was no significant compression, and there is, of course, a mass within the thrombus within the common femoral vein. She's kind of, she had a high BMI, more than 35. So transthoracic echo was kind of, quite difficult to obtain a good quality. I don't know why it's stopping here. I hope. Okay. So anyway, again, transthoracic was not that helpful in identifying any pathology. So we went for TEE. And as you can, from the first look, you can see that a very thin mid-interatrial septum. And then, of course, adding the color, we can clearly see like left to right shunt. And again, a close look at the septum, you can see that incomplete attachment of the primary and the secondary septum, with, of course, left to right shunt. Again, we performed the. I hope you can see it, like especially in the very first beats. That, of course, more indicative that for the PFO is that there is quite clear right to left shunt as well. Patient underwent Amplatzer implantation, and follow-up echo 1 year later showed no residual shunt, and she was doing fairly well. Second case is not a cryptogenic shock, not cryptogenic stroke patient, but just to show the PFO with aneurysmal changes. This is a 36-year-old male with referred for echo for pre-op evaluation for liver transplant. He had Hep C and liver cirrhosis, and I can see the first feature is that the aneurysmal changes in the interatrial septum. This is not moving, but clearly there is a right to left shunt from this, and you can see the excursion of the septum towards the right atrium quite more than 10 millimeters. Again, it was sufficient, to be seen also by color Doppler, the shunt as well. And as you can see here, this is unfast kind of, form. You can see like a circular type. This is because of the cut, through the aneurysm, and clearly we can see as well the color coming from that PFO and aneurysm. This is about 16 millimeter excursion from left to right. That's a high risk for potential future event. But of course, this is not a cryptogenic stroke patient, it's a liver patient. 2018 in the ESC recommendation and guidelines, I think I would encourage everyone to look into it to have a more detailed information about the topic. So in brief, cryptogenic shock is stroke is a stroke not attributable to any definitive cause, that is intra or extra cerebral, large vessel atherosclerotic disease, or even like small small cerebrovascular disease, or any evidence of embolism. Despite extensive, the word is extensive workup for any vascular or serological or cardiac source for embolization other than PFO. PFO with a cryptogenic stroke is a stroke in patients with cryptogenic, no other cause, despite extensive also workup and negative comprehensive workup. Always we have to bear in mind, to rule out atrial fibrillation with extensive, of course, workup, preferably with loop recorder for at least 6 months before, of course, deciding about this PFO as a causative factor. So stroke, we will know, is a leading cause of death and long-term disability worldwide. PFO is present in general population, about 25%. 30% of all ischemic strokes are considered cryptogenic. We can't find, like 30% of stroke patients, we don't find any evidence of cause. 40% in young populations with embolic or ischemic stroke have no identifiable cause. So in younger patients, it is much higher not to find any identifiable cause. In young patients as well, and in patients with cryptogenic stroke, there is an incidence of about 40% of these patients would have associated PFO. Whether it has a role or doesn't have a role, that's again the main question in these patients. PFO is quite identifiable by either TTE or transthoracic or transesophageal or transcranial study. I would like to share with you this actually a very important a score, kind of a table to identify to see whether PFO that could be implicated as a causative factor in cryptogenic stroke. The key factor here, is for each. We can see, it's allotted a point, but you see a cryptogenic stroke in young patients should raise actually a very high awareness, raising actually this, giving it like 5 points. Maximum we can get is 10 points among these patients. So what's the correlation of this, the points and the risk of being the PFO as a attributable cause of the stroke? As we can see, if someone has like 9 to 10 points, there is a 90% chance that the stroke is due to PFO. And of course, the lesser, the lesser. And in terms of recurrent stroke, we can see it declines, most probably because of these patients have already on treatment for their stroke. So anticoagulation, whether it is antiplatelets or oral anticoagulants, is still to some extent until 2017 was quite debatable. And PFO closure, whether surgical or transcutaneously, also was quite developed and took a quite long shot in the management of these patients. So if we go over the literature, we can see we can divide it actually the literature to those studies that were done before 2017 and after 2017. So before 2017, we know that the RESPECT trial and PC and Course 1, Closure 1 trial actually all failed to show any benefit for PFO closure when compared with medical management. But actually those studies, when we go back and retrospectively studied, there were so many biases, and of course there are serious confounding factors in terms of interpretation and conducting these studies. In 2017, three major randomized controlled trials were published. That is RESPECT extended for 5 years follow-up, and close and reduce trials. And there are a few others, like, recent over the last couple of years. So going over these, as you can see, like, Closure 1 and PC and RESPECT short trial showed all actually no significant benefit for PFO closure device versus medical management. And as you can see, all like conducted between 2012 and 2013. Published in that time. When we come to 2017, as you can see, like three major trials that all showed significant role for PFO closure when compared with medical management. In recent study in 2018, actually, there is an update for a meta-analysis combining all studies, even like including those done in 2012 and in 2013 together. If we run them about together, we can still find overall benefit for PFO closure compared with medical management with significant p-value among them. So there is actually about 56% risk ratio improvement in these patients with PFO treated with PFO closure versus medical management. However, this is with the caveat of increased risk of atrial fibrillation, new onset atrial fibrillation, atrial flutter, with 5-fold compared with those medical treatment. But in general, those actually did not have much actually impact on the long term and risk. In recent, also in 2018, in JACC, there was a new also study that specified those patients with what we call high-risk PFO. So those with high-risk PFO, we can look at it, is that the PFO associated with aneurysm, as we had seen in our case, there is hypermobility of the septum, that is excursion more than 10 millimeters. As you can see, remember, our patient is 1.6 centimeters. And of course, the size of PFO if it is more than 2. With the primary endpoint, stroke, vascular death, TIMI, major bleeding, we can see that 2 years event-free was 100% in those patients treated with PFO closure, compared with 87%, that is 13% of them, they develop an event within 2 years of medical management. Some feature about high risk, I think we are all familiar. And the most recent one is actually comparing device-to-device analysis. This is presented in the ASC Congress 2019. And as we can see, this is actually a head-to-head comparison between Amplatzer and Occlutech device. And as you can see, there is little edge for Amplatzer compared with the Occlutech, and of course residual shunting within 1 month and 6 months, there is still statistically significant. However, in terms of risk of, in terms of death and stroke and transient and TIA, all actually pretty much the same. And there is a little trend towards increased atrial fibrillation in the Occlutech device. In general, they are comparable. Within 6 months echocardiographic findings, there was not much significance. So let's, again, all this defense, again, added to the review meta-analysis, again, all showing the benefit for PFO. There was a systematic review and meta-analysis for all the studies comparing the 3 arms of treatment modalities, that is anticoagulation alone versus PFO closure with platelet treatment, antiplatelet treatment. So we can have those who cannot give anticoagulation were given the PFO closure and the antiplatelet, and comparing those with who were able to receive anticoagulant and those who could not receive the PFO closure, and comparing anticoagulation versus antiplatelets. I know this is not much enough time, but I will go directly to the summary. So for PFO closure versus antiplatelet, there is, of course, strong benefit for PFO definitely, with little increase or risk of procedural risk factors and procedure complication and atrial fibrillation, atrial flutter. Again, comparing the PFO closure and anticoagulation, there is also some evidence of benefit. However, it is less prominent than when compared with antiplatelets. And finally, the anticoagulant versus antiplatelet, there is still an age for anticoagulation. Give me just 1 minute, if you don't mind. So there is still benefit for anticoagulation compared with antiplatelet. However, there is, of course, increase on the account of increased major bleeding. However, there is still little edge to favor anticoagulant versus antiplatelets. So the decision should always has to be discussed with the patient in details in general. In terms of cost, of course, there is short term, of course, extra cost for PFO closure. However, on the long term, there is much saving. So for patient selection, we also have to consider the cryptogenic stroke in young patients, usually less than 60 years of age. We have to confirm that the ischemia is confirmed by CT MRI, to confirm the PFO by TE, and we have to perform a comprehensive workup in order to identify any other cause other than the PFO, and especially like atrial fibrillation, we should exhaust any way to identify if there is any underlying atrial fibrillation. And of course, we rely on ROPE score in order to identify those with high risk for potential PFO implicated in the cryptogenic stroke. And always multidisciplinary approach with our colleagues from neurology and of course from the imaging study. All we have to get together and of course to discuss in details with the patient all kind of pros and cons of each modalities. Thank you so much.